This video demonstrates excision of ectopic parathyroid adenoma located in carotid space in proximity to skull base. The prevalence of ectopic parathyroid adenoma is about 2 to 43%, carotid sheath being ectopic location in 3%. Our patient is 18-year-old boy evaluated for pathological fracture of left hip. On evaluation, parathormone and calcium was elevated. CT neck showed lesion posterior aspect of left internal carotid artery. Parathyroid scan confirmed ectopic parathyroid adenoma in the neck. CT cerebral angiography confirmed tumor in the carotid space proximity to skull base. Internal carotid artery was close to the tumor, however, it was not involved. Proper understanding of neurovascular anatomy and planning is must before going ahead with surgery. A retromandibular approach was taken 2 cm below the mandible. The facial vein was clipped and carotid bifurcation was identified. The hypoglossal nerve, lingual artery, facial artery, terminal branch of external carotid artery were identified. The lingual artery and facial artery were divided for better exposure. The external carotid artery was dissected distally up to occipital artery and terminal part of ECA. The occipital artery and terminal part of external carotid artery were dissected all around for better exposure. The external carotid artery was retracted laterally and dissection of internal carotid artery was commenced. The control of internal carotid artery was taken after safeguarding surrounding nerve plexus. The lower part of tumor was identified. Tumor was dissected from terminal ECA and superior part of hypoglossal nerve. The superior part of hypoglossal nerve was dissected all around for better exposure. The occipital artery was dissected all around and divided at the origin for better exposure of the tumor. The careful dissection of the tumor posterolaterally was continued to safeguard superior part of hypoglossal nerve. The medial dissection of the tumor was continued after taking care of pharyngeal plexus and sympathetic trunk. Superiormost dissection was performed to safeguard glossopharyngeal nerve. The dissection continued laterally near hypoglossal nerve. The next step of surgery was to identify vagus nerve posteriorly. Medial dissection of the tumor was continued after taking care of sympathetic and pharyngeal plexus. Meticulous dissection of the tumor from vagus nerve was continued. Superolateral dissection of the tumor near the skull base was performed. Sharp dissection along vagus nerve was performed to separate tumor from vagus nerve. Tumor was free all around except superiormost part which was not visible. Hence, lower part of the tumor was divided for a better exposure of the superiormost extent. Remaining part of the tumor near the skull base was excised completely under vision. The care was taken to prevent tumor spillage and further parathyroidomatosis. This is the resection bed showing all neurovascular structures. Parathormone level at 20 minutes following excision was dropped to 56. Final histopathology reported to be parathyroid adenoma. Hypocalcemia at post-operative period was managed with IV and oral calcium supplement. Patient had glossopharyngeal, hypoglossal and vagal nerve paresis, which was managed conservatively, which was improved at 6 weeks follow-up. Thank you.